Good morning, everybody. I should have learned Welsh. I should have learned to say good morning. So, thank you very much to the Tissue Viability Society for inviting me here today. It's a great honour to be able to present to you. And I think the theme of my presentation follows on very well from what Jonathan was talking about previously around evidence-based practice, evidence-based medicine. And I suppose I'm not coming to you with a solution. I'm not coming to you with, some new research findings in this area. But perhaps what I'd like you to take from this is to maybe to sit back and rethink what we mean by outcomes in wound care, and to start having conversations as to what we understand by outcomes. And I think as a nurse, and I know many of you are nurses, we deal a lot with diversity. So when we talk about wound care, we're looking at paediatric wound care, trauma wounds, surgical wounds, chronic wounds. So there's huge diversity in this area that we're dealing with. And one of the mantras we often say is that I want the best possible outcomes for my patient. But what does that actually mean? Is that what we think the best possible outcome is for the patient, or is it the individual's identification of what is the best possible outcome for them? But not only are we dealing with diversity, we're also dealing with complexity, because the individuals that we are dealing with and working with today have much more complex healthcare needs than they had in the past. We're dealing with individuals, for example, in areas of diabetes, who are dealing with a complex disease. They're dealing with the lifestyle challenges that are inherent in management of that disease, and also a group of people in which the levels of depression are very high in the management of that particular condition. So when we start to look at outcomes, we have to start to take all of this into consideration. But not only are we dealing with diversity, we also have to look at different perspectives. So while we're all in the same situation, we may be seeing two totally different things. So if we look at in a clinic setting, the microbiologist is looking at the wounds and sees this is a great environment. They're seeing one thing. The vascular surgeon is seeing something else. And the tissue viability nurse is seeing something totally different. And the patient is saying, hello, this is what I want. So it's to try and start to see how we can think about all of this in the area of outcomes. And much of it goes back to the whole ethos of evidence-based medicine or evidence-based practice. And Sackett put out this definition back in '76, which really holds true today. And he says that evidence-based medicine is the integration of best research evidence with clinical expertise and patient values. And what's interesting in that Venn diagram that was put out, and nobody's ever really challenged that diagram, is that he did not weight one greater than the other. All three are weighted equal. So it's saying that we may have research here that is showing one thing, but does that fit with patients' experiences and patient values? And does it also fit with our experience and our values? And it's saying to us we need a balance of all three of those. We do not weight one as being superior to another. And it just reminds me in terms of, there's a great buzz, I suppose, at the moment around value and values. And I have to call it a misfortune at this stage. I'm doing a course, and one of the modules is health policy and economics. And the reading around that is so difficult, but it's all about values and, value health systems and everything. And the great thing with economics, it's all, it's really conceptual. But value is about the outcomes achieved relative to cost. So it's an economic language versus values. And in fact, in Ireland at the moment, we have an initiative from our Nursing and Midwifery Board where we're asking nurses and midwives right around the country to identify the values that underpin their practice. And that those values should be based on the principles of the Code of Conduct, which are around respect for dignity, professional responsibility and accountability, quality of practice, trust and confidentiality and collaboration with others. And that word quality is just, it peeps in there. But quality is used all the time, like we have a quality healthcare service. We're delivering quality healthcare. We're looking for quality in terms of outcomes. But again, what do we actually mean by quality? And in the United States, the National Quality Measures Clearinghouse identified almost 2,000 different elements in which quality is measured. Quality is often defined as being about the structure, process and outcomes. But in those almost 2,000 measures, outcomes, true outcomes, only accounted for 7%, and less than 2% of those were patient-reported or patient-valued outcomes. So my point is, we're using words and we're using language, and we need to start to step back a little bit and see, what do we actually mean by that? And what do we mean by that with our patients, our clients? How, what does quality mean to them? And the Institute of Medicine, I suppose, cautions us in that it says that practice inconsistencies are negatively impacting on health outcomes and the cost of healthcare. And the cost of healthcare is one of the greatest fiscal challenges affecting nations right throughout the world, because they are rising far beyond what we can be expected to deliver. And it warns that evidence of effectiveness, when absent, results in care that is fragmented, uncoordinated and characterised by unnecessary duplication of services. But where do we get the evidence of effectiveness? Arguably, most of it is from research and from randomised controlled trials. But how do we keep up to date with that? It's virtually impossible. In fact, something I read there recently, and it said that if you take reading documents and even guidelines and papers, it takes on average about 2 minutes per page to read. So when our economics module leader gives us yet another 70-page document, I'm calculating, thinking, where's the summary? But essentially, we have about 10,000 new RCTs a year just in Medline alone. Cochrane have identified about 350,000 new trials. But interestingly, studies in the USA and the Netherlands would suggest that about 30 to 40% of patients do not receive care according to present scientific evidence. And that follows from what Heidi showed this morning in terms of assessment for suitability for compression therapy. And about 25%, about a quarter of care interventions, it's argued, are not needed at all. So more specifically in the area of wound care, and we just look at a European context, and we've got a UK-Ireland context at the moment, but if on a European context, if we see that the population in the EU with diabetes is about 20 million, those who have diabetic foot ulcers account for just over 1 million, or 1.4, which we know is increasing, with a cost per episode of about 400 to 600,000. So an annual cost in the EU of managing diabetic foot disease is about 4 to 6 billion euro. The adult population in the EU is about 414 million. Of those over 65, about 85 million, and a leg ulcer prevalence which affects just over 1 million people. And the cost per episode is over 6,000, with an annual cost of about 6.5 billion. And what Posnet and those argued, and very well, was that they would say how many of those patients are receiving appropriate care. And when we look at the number of patients and the costs incurred, it's a very important question to try and address. It's also important to address it in terms of diabetic foot disease, where we see that 5-year mortality rates from diabetic foot disease are around 50%. Which is higher than some of the most common cancers, including breast cancer and prostate cancer. And yet, the focus that is on these is much, much less. So, part of the reason also that we need to look at outcomes and perhaps recalibrate our thinking around outcomes comes from various sources. But this paper, and it was not specific to wound care by Dwan and those, they looked at evidence of selective outcome reporting. And one of the things you have to remember, particularly in randomised controlled trials, if I decide to set up a trial, I arguably set it up with an outcome that I am interested in. So if it's about a product, I might be looking at product performance, I might be looking at infection rates, I might be looking at costs. But I have set the agenda as the investigator of that trial. But what was interesting in this was that studies reporting positive or significant results are more likely to be published. And we've known that for years. Now, there is a greater shift away from that, in that by registering of trials and also follow-up of protocols of trials that have been registered. But it means that we are basing our evidence on a skewed set of results, because we're only basing it on those trials that gave us a positive result. We're not seeing the trials with a negative result. Also, we know that outcomes that are statistically significant are more likely to be fully reported. But what was really alarming was that just over 60% of trials had at least one of the outcomes changed, newly introduced, or omitted compared to the protocol. So the protocol set out, we're going to look at infection rates or whatever it is. We didn't get that result, but actually we got another result. So really what we wanted to look at was B. So they actually changed what it was they said they were going to do. And a further study that was published last year showed that 80% of wound care trials are not big enough to show a meaningful difference. So in the field of wound care, we have all this activity going on. Arguably it is getting better, but we've been producing evidence that is still not giving us the answers to the questions we have, and particularly the questions we have in clinical practice. A study that was done by Hodgins and Goetz in 2014, and they looked at 167 trials in wound care. Half of the trials followed up patients for less than 12 weeks, and half of them had a sample size of less than 63 people. So if you look at the numbers of people with wounds, half of the trials upon which we are basing our evidence have sample sizes of less than 63. But also, 41% of the trials did not say what the primary outcome of the trial was. So they never actually stated within the method section what it is this trial is supposed to be looking at. So how can you as clinicians, how can people who are trying to develop guidelines actually make sense of all of this? We published a paper last year where we looked at 102 randomised controlled trials in venous ulcers, and we found pretty much the same thing. And this was specific to venous ulcers. The other one was all types of wounds. Half of the studies had sample sizes less than 83. 39% failed to report a study endpoint. But also, when it came to how they measured the outcomes in the trial, how they measured size, exudate, all the different variables in the trial, 95% of them, almost all of them, made no reference to the validity or the reliability of the methods used to assess them. Size was the most frequently used method to assess them. Photographs was used then. And then when they looked at areas like exudate and odour and things, we have such a range of scales. Scales went from 0 to 3, 0 to 5, 0 to 10, 0 to 100, word scales, picture scales. So you can imagine the difficulty when we try to add these together and say, well, what is the evidence to support X? Well, we actually can't add it together because everybody measured it in a different way, in a different type of a trial, with a different type of a wound that had a different primary outcome. A further study that was done from the US, and it looked at 60 studies in venous leg ulcers. And the results of this and the conclusion they saw was that we could not draw definitive conclusions regarding the effectiveness of advanced wound care dressings in terms of intermediate and other final outcomes, including quality of life and pain measures. So there's no doubt that there's a need to start to shift our focus. And where some of this comes to the fore is in the use of guidelines. So we've seen in the last few years a lot of guidelines that have been updated in pressure ulcers, diabetic foot ulcers and venous leg ulcers. And these guidelines, to guide us in practice, are dependent on the evidence base to support them. And just as an example, in guidelines for the management of venous leg ulcers came up with 86 different recommendations. It sounds a lot, but they're actually presented in a very clear, concise way. But it does run over 59 pages. And only one of those had grade 1A recommendation, which is based on high-quality randomised controlled trials, and that was for compression therapy. So in this whole arena of venous leg ulceration, we have only one modality that we can truly and strongly say this is effective. And in the prevention and management of pressure ulcers, these recommendations are over 86 pages, and only in the area of assessment, there was no grade 1A evidence. And assessment is the cornerstone in terms of prevention. So what are the outcomes that we do want, and how can we start to create a dialogue and to create a discussion around this particular area? And one of the interesting starting points, or maybe a finishing point, is that the Food and Drug Administration in the USA, which licenses products as wound care products as medical devices, they claim that complete closure of a wound is the most clinically meaningful endpoint. And they define it as skin reepithelialization without drainage or dressing requirement confirmed at 2 consecutive study visits, 2 weeks apart. So it distinguishes healing from closure. So if we go back to trials, that is a big challenge in the evidence that's out there, because many of the trials actually defined healing as when a wound is closed. But they have made a difference in that. But they're saying it's the most clinically meaningful outcome. And maybe it is. But in many patients that I have treated over the years, particularly with venous ulcers that are recurrent, that to them is not really what they're after. They would like their wound to heal. But to them, I want to be able to wear stockings because I want to be able to wear my shoes. I do not want pain. I do not want to be able to go to Mass or go to my niece's wedding and that my wound is smelling. These are the outcomes that patients will say to you that they want solutions to. And if you look in some of the research, odour is the biggest challenge that patients complain about. It's also the biggest challenge that clinicians complain about, yet it is an area we have the least amount of research on. So it may be clinically meaningful and it may be the gold star, but I'm arguing it's not the only star that we can have. So in terms of defining outcomes in wound care, one of the things we have to consider is whose perspective do we define them from? And we should be defining them from all perspectives, from the patients, the clinician, from industry, from services, and from the payers, including insurance companies, NHS, or personal payment systems. So if we had this individual patient with a pressure ulcer, what would be the outcomes that this individual patient would want? Would it be free of pain? Would it be able to lie on his back again? These are the type of patients that we have to deal with in terms of finding solutions to some of the problems. But would this patient be included in a trial in the management of pressure ulcers? Probably not. The size of the wound would be too large for the trial. The complexity of the patient would be too much for the trial. So therefore, would the trials that we do in the management of pressure ulcers relate to this individual patient? If we look at another case, 75-year-old lady with lower limb ulceration, what is the outcome for this patient? Is healing really the outcome? Is it a potential outcome? Maybe in the long term it may be, but in the short term, is it truly the outcome? And again, would this individual patient make it into a trial? Probably not. So what outcomes do we assess to determine choices? And previously it's reported that we have 3 E's of wound care. Is it effective? Is it economical? And is it efficient? And all of those are still valid today, but they fall short of the questions we should be asking of many of the interventions. And with this, there's an initiative that has been around for a few years called COMET Initiative, and I would urge you to check out the website and to look at this area. And COMET stands for Core Outcome Measures in Effectiveness Trials. So the focus is on trials in wound care as opposed to other types of research studies. And they look at developing what are called core outcome sets. And the definition of a core outcome set is an agreed, standardised set of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of health or healthcare. So it's saying, what is it as a minimum should be reported? It is not saying this is the only thing that should be reported, but in any trial, what do we want as a minimum? A core outcome set considers both benefits and harms. It says what is to be collected as a minimum, but others can be collected. And the focus is only on trials of effectiveness at this point in time. But crucially, the outcomes identified should be relevant to clinical practice. And it identifies what to measure and then how to measure. So it starts off with, what are we going to measure in future trials in, for example, prevention of pressure ulceration, management of venous leg ulceration? Then, how are we going to measure it? Do we use a simple wound grid in terms of measuring size? Is that the best method to measure that outcome? And then how valid or reliable is that method in measuring that outcome? The scope of it is that it looks at specific areas of health or healthcare that the cost or the core outcome set is to apply to in terms of the health condition, population and types of interventions that need to be determined. It can include all stages or severity of a specific condition, or it may be focused on a particular disease category. For example, we could develop a core outcome set for diabetic foot ulceration, or it might be just focused on those with neuropathic foot ulceration. It could be looking at all treatment types or a particular intervention. For example, it might only be around a cost for studies that involve the use of compression therapy. The advantages of them are quite significant in that they increase consistency across trials. It maximises the potential for trials to contribute to systematic reviews of key outcomes and therefore contribute to guideline development and in helping people in practice. They are much more likely, therefore, to measure appropriate outcomes. You get a reduction in selective reporting, which we saw earlier, where trials only report what they want to report. And the key is that there is inclusion of all stakeholders and respects different perspectives. And these stakeholders are all that we have said, but crucial to this is the involvement of patients at an early stage and at all stages. And this is what's called the PPI, or the patient and public involvement, in which the research is carried out in collaboration with people, with them or by them, rather than to people or for people. So it includes people actively in all stages of the process. And according to Sir David Kuski in 2006, it can address this translation gap, because he would argue that the biggest challenge is not the production of more research studies, but the implementation of findings of those already carried out. And the James Lind Alliance, which many of you are familiar with, and Ian Chalmers would say, that we need to recognise that patients have the experience and the skills that complement the researchers. They know what it feels like to suffer a particular disease and to undergo the treatments with their various side effects. They will have a good idea of which research questions are worth asking and when a question should be framed differently. They are the centre of all of this dialogue. Organisations, just websites there in the US, PCORI, in the UK, Involve, and in Ireland, IPOSI. And these are more actively engaged in this process. So where to next? Well, essentially, we need to start to develop a common language in wound care. We need to develop core outcome sets for different wound etiologies. We do need larger trials. And as clinicians and practitioners, you need to consider what level of evidence will you accept in order to change your practice. And one initiative, and we'll be speaking about this in more detail tomorrow, is a group of us who are setting up, we're at the early stages of a project called CoreVen, which is to develop core outcome sets for reporting of clinical trials for the treatment of venous leg ulceration. And I'm pleased to say it's an international collaboration with some really experienced people in this field. So we're looking forward to doing some work on this. So in summary, we know that wound healing is a complex process. We need to start to define through consensus a set of outcome measures in different wound etiologies. Core outcome sets are required to build this area, and patient and client involvement is paramount to the success. And we need to avoid what's called eminence-based practice, which is making the same mistakes with increasing confidence over an impressive number of years. And I would argue that if we make healing the only outcome, then we lose something, and we lose the ability to move beyond itself. And hopefully, we'll all be looking in the same direction. Thank you.
Thank you, Georgina, and thank you, Jonathan. We are running a little over because we started a little late, and I know you're all probably desperate for a cup of tea or coffee. The break is open till 11:30. Next sessions will start at 11:30. However, I think we've had two very interesting opening sessions there. We've probably got time for one or two questions, if anybody's got a question. We've got some microphones around. Anybody want to ask a question? If not, I might ask you to, if Jonathan's willing to stay for the break or a few minutes in his busy schedule, perhaps grab them at lunch. And I'll let you all get back to break. Thank you very much, Jonathan and Georgina. Thank you.